No, the drug cards.
Okay, so let's go ahead and get started with the nervous system. Yes?
You said that there was some application for the drug cards. It was Hippocrates.
Yeah, there are a bunch of stuff online, a bunch of things that you can go and research. And I put some in your notes, if you remember, from the...
It has all of it.
Yeah, I also added a drug guide to the library in the back. It's a 1998 drug guide. It should be back there. If you're free to use it, please don't take stuff home, however, because that stuff is there for everybody. But you should have a drug guide back there. There are a bunch of websites. Hippocrates is an app that you can download if you have an Android or an iPhone. Micromedics is another really good reference. You can access that online. I think it requires that you set up an account, but it's free. Really good. Tells you a lot of information about the pharmacodynamics, pharmacokinetics. Micromedics was also in your PowerPoint for that first lecture, so you do have those resources. It's just a matter of going to Google and looking them up, and it'll take you right there. So, like I said, you got those back there, online resources. Wikipedia, probably not a great resource to use. Sometimes it's good, sometimes it's not. There isn't a whole lot of peer review going on there. Okay, so let's go ahead and talk about the pharmacology of the nervous system. Did you guys find the PowerPoints a little confusing? Anybody? Maybe, yes. I see some north and south movement of the head. Okay, so let's try to break this down just a little bit and kind of simplify it. And hopefully if everybody is okay with the nervous system physiology, I can spend a little time on the second half of the lecture reviewing for your exam next week. You will have an exam next week. It'll be 20 questions, so it's not very long. And you'll have about 25 minutes to complete it. So just a little over a minute per question. The reason I do that is because when you take your boards, you're going to have a minute a question to get through your boards. So, yeah, and I actually have Scantrons, so you don't necessarily need to bring a Scantron. But it'll be on Scantron. We'll run it, get your grade really quick. That's generally how I'm going to run the pharmacology tests. They're not going to be very long. They're not going to have a whole lot of craziness in them. They're to the point, and that's what I want to know. And that's what you're going to need to know for board exams. Now, with that said, you're probably going to encounter some very crazy pharmacology questions in some of your other classes. You may end up talking about medications that are no longer used and haven't been used in 20 years. So when we start covering the classes, I may make mention of, hey, there's a table here. You may want to look at those medications, even though you'll never use them in the clinical environment. For whatever reason, they still like to ask questions like isoephrine and isopril and certain medications that really aren't commonly used. The focus of this class, however, is going to be on the common medications that we use to get you guys ready for clinicals next semester, I believe, right? You guys start next semester, so that's where the focus will be here. So we'll talk a little more about the exam, and we'll do a quick review of that toward the end of class. So let's go ahead and talk about the nervous system. Why do you think we actually talk about the nervous system here?
Because it's drug-related, how it affects you.
Okay, it's drug-related. Where do you think most of the medications that we give work?
On the receptors?
On receptors, and what receptors do you think we are primarily dealing with?
Is it the sympathetic system?
Okay, sympathetic, parasympathetic.
Most of them.
I think it's safe to say that most of the medications that we give in respiratory therapy, most of the medications we give will act upon the nervous system in some way. There are some medications such as antibiotics, anti-infectives, and some of the cardiac medications that don't necessarily work on nervous system receptors. However, most of the medications we give will work on nervous system receptors, specifically the bronchodilators. So you guys have started your drug cards. You probably have written a lot of beta 2 receptor, right? That's a recurring theme in respiratory therapy. So we will talk about these various receptors. So let's just go ahead and talk about the nervous system in general. I have two major components of my nervous system. What are they? The two major components. Central and the peripheral. Okay. So let's go ahead and just start right there. And my drawing, I apologize, my drawing isn't all that great. But if you can imagine that that's a brain, and this is a spinal cord, what will we call this here? Okay, everyone would agree. Everyone can see that? You guys in the back, it's okay? All right. So we call this the central. And there is a picture in your PowerPoints with a whole bunch of boxes. And I find that kind of confusing. I like pictures. I like real pictures. So we'll go ahead and do the real picture, but if you like words in boxes, you do have those in your PowerPoints. But let's go ahead and just draw this out. Central, brain, spinal cord. What composes the central nervous system? What are the composite cells? What composite cells?
Are they neurons?
Neurons, okay, good. So we have neurons. And what is the basic structure of a neuron?
Like the body axis.
Axons.
Okay, so we have axons, dendrites, and cell body. Everybody's okay there? And the most common neuron that we run across in the human body is something called a multipolar neuron, right? There are two other types. So you have bipolar and monopolar. Those are primarily associated with sensory. Like bipolar neurons are primarily vision. We're not going to focus on those. What we're worried about are the multipolar neurons, and they compose about 99% of all the neurons. So if you can imagine, I have the cell body here. I have an axon that goes away from it. And then I have a terminal ends of the axons. And then from the cell body, I have these little dendrites. Again, I'm not a great artist. I'm not Picasso or anything like that, so. Okay. And then I have a nucleus somewhere in the cell body. So we have the body, the axon, and dendrites. Everybody can see that. Where does a neuron receive signals or impulses from? Okay, so dendrites receive signals. And how do we transmit signals? How are signals transmitted to neurons primarily? Chemically, and what are those chemicals called? Neurotransmitters. Okay, so neurotransmitters, and we'll talk about them in a little more detail here in a little bit. So neurotransmitter will attach, and that signal will then propagate its way through the dendrite, the cell body, and ultimately down the axon to the end of the axon, and of course that little space at the end is called a synapse, right, or a synaptic space. And then neurotransmitters are released from the terminal end of the axon, and they act upon either another neuron or some sort of receptor. Everybody's okay there? How is this signal propagated, this impulse? How does this impulse actually move? What's happening? What is it called, first of all, this signal? It starts with an action.
Oh, potential.
Action potential. Good. Action potential. That's why we're reviewing this. Okay. What happens with an action potential? So if I were to zoom in here, I'll draw a little circle here, and we'll zoom in on the cell membrane. And here I have the membrane. This is inside, and this is outside. Everybody can visualize that okay? All right. So what electrolyte or cation do we have normally inside of the cell? Potassium, right? Potassium is the chief intracellular cation or intracellular electrolyte. And what is on the outside? Sodium is the chief extracellular cation or electrolyte. What happens with an action potential is the neurotransmitter comes along here, it attaches to a receptor, and generally what will happen is a sodium channel will open up on the membrane. So I'll draw a little sodium channel here, and we learned from the first lecture that those are proteins, and the conformation of that channel will change. It'll open up. And what's going to happen when that channel opens up? Where's sodium going to go? Sodium's going to rush into the cell. Where will potassium go? Potassium will rush out of the cell, and the potential, the electrical potential across that membrane will what? It's going to change, right? It's going to change. The resting potential is what, right around 100 millivolts, somewhere in that, negative 100 millivolts, somewhere in that range. The potential change across that membrane, and then all along that membrane, what's going to happen? These channels are going to open up, sodium rushes in, potassium rushes out, and that signal is propagated, or it moves down through the cell as sodium rushes in, potassium rushes out. Then what does the cell do to in essence, reset itself? And how does the cell go back to the resting potential after the signal goes through?
It reaches,
Well, what happens? What needs to happen for the cell to go back to resting? Okay, what needs to go back into the cell? Potassium needs to go back in, and what needs to go back out? Sodium. So I have to have a reversal of that action potential. And what does that? So does the sodium channel need to close? Yeah, sodium channel needs to close. So I need to get rid of the neurotransmitter that had opened that channel in the first place, right? Need to get rid of that. Sodium channel closes, and then the sodium-potassium pump kicks in, and it pumps sodium out of the cell and potassium back in, and we go back to the resting potential. Is everybody generally okay with that? And that's just basic anatomy and physiology, and I know you guys have all had that, but now that we're all on the same page, we're okay with how neurons work, generally speaking. And obviously you guys probably went into a little more depth than we're going to do here in anatomy and physiology. Okay. So we have the central nervous system, and we have the peripheral nervous system. All right. All right. Now, the body has ways of sending information out and getting information in. Would you guys agree? That getting information into the brain, or the central nervous system, so getting information in is generally going to be sensory, right? And the body senses. That's how we sense. My eyes, for example. I have visual input. Photons smash the back of my retina and activate neurons, bipolar neurons, and the signal goes into the brain. If I touch something hot, that signal goes up through a sensory, what we call pathway. And what is another name for a sensory pathway or an ascending pathway? Afferent. And that starts with an A, an afferent. A-F-F-E-R-T, I believe. Okay, now let's say that the body, the central nervous system, wants to send a signal out to the body. Generally, that will be a motor signal, the heart to beat, my arms to move. That will be a descending signal, generally motor. It's a descending pathway. And what do we call that kind of pathway? An efferent. So with an E instead of an A. Are you guys okay on afferent versus efferent pathways? Okay. Ascending, descending. Good. All right. So let's kind of get into the meat of how all this is going to work. So we talked about the central, we talked about the peripheral. I have two different branches of the peripheral nervous system. What are they? Somatic. Okay. Somatic. And autonomic. Autonomic. And which one do we have direct control over? For the most part? The somatic. Would everyone agree? Okay, so the somatic. So what is the somatic nervous system? Mainly it's skeletal muscle. Would you guys agree? Skeletal muscle. All right. Somatic nervous system. Skeletal muscle. All right. Good. What about the autonomic? What's going on with the autonomic here?
Smooth muscle, digestion, cardiac muscle.
Generally, let's generalize autonomic a little bit. Autonomic, do we necessarily have control over that? No, we don't have direct control over that. Now, there are some cases, people, well, I meditate, I do this, and I do that. You're correct, but as a general rule, the autonomic nervous system is the automatic nervous system. That's kind of how I look at it. It kind of controls things. And where do you think most of our where we're going to be concerned with most of our drugs? The autonomic nervous system. Most of the medications that we'll give in respiratory therapy are going to affect the autonomic. All right? Are there different branches of the autonomic? Yes. How many branches are there? There are 2 branches. What are they? Parasympathetic. Parasympathetic and sympathetic. All right. Okay, what do they generally do? What does the parasympathetic nervous system generally do?
Rest and repair, eat and sleep.
Okay, feed and breed, eat and sleep, rest and repair. Okay, slows things down. That kind of response. How about the sympathetic nervous system? Fight or flight, okay. So generally we speed things up. Now, sometimes we tell people that these 2 systems fight, they're competing. What do you guys think? No, they're complementary to one another. And is there ever a state where you have one totally take over under normal situations? Even when I'm running, let's say I'm running from a bear or what have you, is my sympathetic nervous system totally 100% in control? No, there are still parasympathetic functions that are occurring. So basically they're complementary to one another, and depending on the situation and circumstance, one can kind of kick it up a notch, and then kick it down, kick it up, kick it down, depending on what's going on. So don't look at these as competing necessarily, but as more like complementary. But when we talk about respiratory therapy and there are certain problems or conditions, then we can run into a problem that causes more of the parasympathetic or less of the sympathetic, and then we run into issues with bronchospasm, secretions, mucus production, things like that. But that's a problem. Under normal circumstances, these 2 branches are complementary. Now, do the sympathetic and parasympathetic branches come off of the central nervous system at different points? The nerves that branch from the spinal cord, do they come off at different points? What do you guys think? So where does a major portion of our parasympathetic nervous system branch off? What part of our central nervous system will that branch off at?
It's going to be the peripheral, right? Because the sympathetic is...
Okay. Well, where on the spinal cord would you guys think? High, low? High? Okay. We're close.
Low.
Think about the cranial nerves. You guys remember on all the Olympus towering tops? Remember memorizing the 12 cranial nerves? Is there a cranial nerve that supplies a significant portion of the parasympathetic nervous system? What is the name of that nerve?
Is it the vagus nerve?
The vagus nerve. What number is it? 10. All right. Cranial nerve 10. So a lot of our parasympathetic nervous system comes from cranial nerves or comes very close to the brain itself off of the cervical area. The vagus nerve actually is a cranial nerve. It comes directly out of the brain. Okay. What about sympathetic nerves? Where do they branch off at?
Spine.
Off the spine. Which part of the spine would you think? Upper, lower? Mid?
Bottom.
What do you guys think? Mid?
The bottom.
The bottom? The mid? That's a good guess. That's a really good guess. The thoracic vertebrae. Most of your sympathetic nerves branch out of the thoracic vertebrae. Okay, those of you that are in medicine right now, when somebody has a spine injury, and that injury occurs at the thoracic vertebrae and above, what condition can that patient go into? We call that,
Paraplegic?
well, yeah, but there's something called spinal shock or neurogenic shock, where their blood pressure gets really low, their heart rate gets really low from a spine injury that happens at the thoracic vertebrae and above. And the reason that occurs is because I cut the sympathetic nervous system off. If we know those sympathetic nerves branch out of the thoracic vertebrae, if I break the spinal cord at the thoracic vertebrae and above, my patient is going to be at risk for going into that spinal shock, right? Because I basically cut the sympathetic nervous system off. So what do I have left over? That's all I have left over. What happens to my heart rate? It gets low. What happens to my blood pressure? It gets low. And anybody who's seen a patient in this spinal or neurogenic type of shock, if you've seen it, you'll always remember it because they look very, very weird. They have a really low heart rate, really low blood pressure, and they've had some sort of spinal injury. Now, you don't typically see that with lower injuries, let's say lumbar, sacral, coccygeal types of spine injuries. You generally will see it with thoracic and above, because that's where your sympathetic fibers branch out at. Okay, so we're good there. So we have the autonomic, and you guys would agree that I have the parasympathetic and the sympathetic. You guys are good there? All right. All right. Everybody can see, you guys in the back can see this okay? All right, good deal. So, do nerves generally, if I have a neuron, let's say right here in the brain, does that nerve go all the way uninterrupted out to the body? Do I generally have a completely uninterrupted pathway? No. I have kind of a dividing line, if you want to look at it that way. I have a dividing line. Now, if we're talking the somatic nervous system, believe it or not, yes. The somatic nervous system is, and it even says that in the book, I believe, that it is kind of a one nerve system, or in essence, I have a neuron in the brain, and it goes all the way out to the skeletal muscle. So we don't have to worry about that here, but we do have to worry about that down here in the autonomic nervous system. And that dividing line is called a ganglion. You guys remember reading about ganglia or ganglion in the book? And I believe that it says a ganglion is nothing but a nerve outside of the nervous system, or central nervous system. I believe it says something to that effect in the book. That's not entirely correct. That's not the definition that I want to use for a ganglion. A ganglion is an area or a group, an area where I have groups of neurons coming in, and I basically have a synapse at that area. Everyone would agree? Everyone knows what a synapse is. And it's basically a dividing line. So I'll say ganglia for plural. It's basically a dividing line between the central and the peripheral nervous system. Central nervous system kind of ends here, and then the peripheral nervous system kind of picks up. Everybody's okay there? Basically what's happening with the ganglia, where the neuron that was in the central nervous system ends there. And I have a junction, or I have a synapse there. Everybody's okay? Everybody follows me so far? All right. Now, everything before this ganglia is called preganglionic. Preganglionic. Everything after the ganglia is known as postganglionic. That'll be important when we talk about neurotransmitters. Is everybody okay up to this point? You guys all right? Okay. So, I'm going to stop there, and I want to start talking about neurotransmitters real quickly. So we have two general types, two broad types of neurotransmitters. Would you guys agree? And what are the two broad types of neurotransmitters? Okay, so acetylcholine, everybody's okay? And you'll often see acetylcholine abbreviated as ACH. And you'll definitely see that on exams as well. What is acetylcholine? Yes, it has a protein-like component. What it is it's nothing but acetyl and choline. And we, of course, you guys are familiar with the Kreb cycle, or the tricarboxylic acid cycle. We know that pyruvic acid is turned into acetyl coenzyme A as it enters into the Kreb cycle. Guess what? That's where we get our acetyl from that cycle. It's one of the intermediate molecules. So I have acetyl, and then I attach choline, and somebody said it was a protein, and you're sort of right in that there's a nitrogen group in the choline. Okay. You're not going to have to identify the molecular structure of acetylcholine, but it looks something kind of like this: CH3. Everybody can see okay. Then a carbon, a double bond with an oxygen, and then a CH2. Everybody can see okay. Another CH2. A nitrogen, it's ionic, it's a positive charge. Then I have a CH3 here, a CH2 here, and a CH3 down here. Yeah, it's got to be a CH3. And this right here is the acetyl group, and this right here is the choline. Now, don't worry, you're not going to have to memorize that for the test. You're not having to memorize this for the test. But I have my acetyl group, my choline group. Okay. And this attaches to what's known as a cholinergic receptor. Anything that acetylcholine binds to is cholinergic. Okay. Everybody's okay with there? If I say the term cholinergic, that pertains to acetylcholine. So if I were to say cholinergic response, it'd be a response based on the of whatever acetylcholine is causing. If I were to say anti-cholinergic, what does that mean? Anti-cholinergic is antagonizes acetylcholine. Everybody's okay there? On a cholinergic versus anti-cholinergic response? Or medications even? Okay, it all has to do with this neurotransmitter here. All right. Before we go on and talk about the other types, how do I break acetylcholine down? What facilitates the breaking down of acetylcholine? It's an enzyme, right? ACHE. And what else do we call that? Acetylcholinesterase, or sometimes they'll call them plasma cholinesterase. So, ACHE breaks acetylcholine down. And basically what it does is it does this. Breaks this bond here and breaks it down into acetyl and choline, and then acetyl and choline goes back into the neuron, and it's kind of linked back together into acetylcholine. So that's pretty handy. So pretty handy. You think it's very quick? You think we can break acetylcholine down rather quickly? Yes. Yes, we absolutely can. And we need to be able to break it down very quickly. And we'll talk about why that is. Okay, so acetylcholine, the enzyme that helps break it down is acetylcholinesterase, or ACHE. Everybody's okay there? All right. Yeah. We'll move on. Another word about enzymes. Do enzymes make stuff happen that wouldn't happen normally?
Yeah, they're catalysts.
Do they? It's a kind of a trick question. Do you think acetylcholine would break down on its own if I didn't have cholinesterase? Eventually. Eventually. That's the key word. Enzymes don't do magic. They don't make stuff happen that wouldn't happen normally. What they do is they speed it up. They make it more efficient. Or they do what we would call in chemistry, they decrease the activation energy of a chemical reaction. And that makes the breakdown of acetylcholine much more efficient. And you guys in cardiopulmonary anatomy and physiology, you are learning, have you learned a little bit about acid-base, carbon dioxide transport in the body? What happens? What do you remember from A&P? What happens to carbon dioxide in the body? Is our body really good at transporting gases? Do gases, because they're small nonpolar molecules, dissolve well in blood, which is water primarily, which is a polar substance? Do polar molecules and nonpolar molecules interact well? No, they don't. So to get rid of carbon dioxide, is it very efficient trying to dissolve it as a gas in the blood? No. What do we have to do to it?
Do you make carbonic acid?
Okay, yeah. So what happens is carbon dioxide combines with water, makes carbonic acid, but carbonic acid is very unstable. It breaks down into bicarbonate and a hydrogen ion. And is bicarbonate charged? Yes, it has a negative charge. Is hydrogen ion charged? You betcha, it's a positive charge. So are they polar? In essence, yes, they're polar. They have a charge to them. Do they interact well with water, which is a polar molecule? Yes. Charged things interact very well with polar molecules. Water happens to be a polar molecule. So we transport most of our carbon dioxide in the form of bicarbonate. Now, would carbon dioxide normally turn into carbonic acid when mixed in water? Would that normally happen? What do you guys think? Well, think about it this way. What happens before it rains? Does it kind of smell? Does it kind of an odd smell, and it kind of smells kind of like a bitter, odd smell just before it rains? What do you think that is? It's carbonic acid. That's carbon dioxide in the atmosphere mixing with the water to cause that acid. So it will normally happen, but is it very efficient? No. So we need an enzyme to make it more efficient, and that's where carbonic anhydrase comes into place. So I gave you guys just a little heads up on your acid-base stuff that you're going to hit a little later on when we talk about gas, carbon dioxide, and oxygen transport. But getting back to the nervous system, so we're all good on what enzymes do. They are, and if you're still a little confused, I think about it kind of in a crude way, and that is, say you're at a bar, and you're a good friend. Everybody's a good friend, right? Let's say your friend has had a little bit too much to drink, and he or she has gotten themselves into a situation where they're fixing to fight somebody else who's probably had a bit too much as well. And they're kind of staggering around, and there's not really a whole lot going on. Well, what do you do if you're a good friend? You jump in, right? You jump in, you hold the other guy down, and then you tell your buddy, okay, I've got him, I'm holding him down. You take a whack at him there, right? Good friends do that? No. You just watch, right? That's kind of what enzymes do, is they kind of hold molecules into place so another molecule can kind of ram into it and make that reaction a lot more efficient. Because what are happening in normal chemical reactions, stuff is just kind of randomly floating around and moving around, and we can take some of the randomness out of that and stack the odds in our favor with enzymes. Okay, so let's go ahead and move on to the other types of neurotransmitters, at least when we talk about autonomic, the autonomic physiology. So acetylcholine. What are the other major ones? Okay, so we have what are called our catecholamines. We have our catecholamines, the class of substances. Okay. What are the major ones that we run into in the body? The two major ones that we'll talk about today. Somebody mentioned one. Norepinephrine, okay. Norepi and epi, okay. All right, so catecholamine. All right. And this is actually something that I am going to want you guys to know because it's just so important. What is a catecholamine? There are three things that define a catecholamine. Very important because this molecule will define most of what we do in pharmacology. So 3 things that define a catecholamine. 1, I have to have what's known as a benzene ring. A benzene ring. 2, I have to have 2 hydroxyl groups. 2 hydroxyl groups. And 3, I have to have an amine side chain. What does amine basically mean? A nitrogen. There's a nitrogen involved. Okay. So norepinephrine, epinephrine, all of the catecholamines all have the same basic structure. And that is, they look like this. Okay. These are all carbons here. Okay. This is what's known as a benzene ring. Let's see. Skip. There we go. All right. And every other bond is what we call a double bond. And this is what's known as a resonance. Is that very stable when I have a structure like this? Is that stable or unstable? What do you guys think? Unstable? Stable? Does this increase or decrease the energy of electrons, energy levels of electrons? What do you guys think? Decrease? Okay. And where do electrons like to be at high or low energies? You remember from chemistry, if I have a naked atom without any electrons, where do the electrons want to go first? Where do they fill first? What energies? Low or high? Low. Electrons prefer low energies. This is a very low energy arrangement. The benzene ring is one of the most stable structures that you'll find in nature. Very stable, critically important, certainly important in what we do. Okay, so then I have the benzene ring. And then I have my hydroxyl groups. That's just a hydrogen and an oxygen. Okay. And then off of this carbon here, I have a side chain. Okay. And of course that's an amine, so it's going to have a nitrogen in there somewhere. And depending on how this side chain is configured, that kind of tells us which type of catecholamine we're talking about. Epinephrine and norepinephrine have slightly different structures, but the 3 underlying things that we care about, the benzene ring, the hydroxyl groups, and the side chain with an amine, are always the same. Always the same. You have to have those to have a catecholamine. I should say that we do number the carbons in the benzene ring, and the number won't be important until we talk about bronchodilators. Then it'll become important, but I'll go ahead and just introduce you guys. This carbon is what we call number 1 here, and then what we'll do is we'll go around counterclockwise. 2, 3, 4, 5, 6 carbons. So sometimes you'll see a word 3'-4'. You ever seen that in chemical names? What that means is that's talking about the carbon. So at 3', I have a hydroxyl group here, and then at 4', I have another hydroxyl group. That's all. And you guys remember the 3', 5', cyclic adenosine monophosphate, or CAMP? Something we're going to talk about with bronchodilators. That's what the 3 and 5 refers to, is where the carbon is. Or there's a group on that carbon that's of importance. Okay. So that's what a catecholamine is, a basic structure. These are really what you have to know. Benzene ring, 2 hydroxyl groups, and an amine side chain. When we start looking at bronchodilators, this will become a bit more important. Okay, so catecholamines, epinephrine, norepinephrine. Everybody's good there? Okay, good. All right. So let's go ahead and now start filling some blanks in on our little drawing over here. All right. So let's just talk about the somatic nervous system real quick. There is no ganglia there, right? Everyone would agree there's no ganglia. So the somatic nervous system, the nerve ends, the axon ends right at what's known as a neuromuscular junction or an end motor plate. So this is a neuromuscular junction here, and this is a muscle. And what neurotransmitter do you suppose is released here? What do you guys think? Acetylcholine? Would you guys agree? How about you guys in the back? Okay. Yes, acetylcholine is the primary principal neurotransmitter of the somatic nervous system. Remember, there is no ganglia, however. It is a one-shot deal. Everybody's okay there? All right. Let's talk about the autonomic nervous system now. Now again, the somatic and autonomic are both part of the peripheral. Everybody's okay there? Okay. Let's go to preganglionic, right here. What neurotransmitter do I deal with in the ganglia of both the parasympathetic and the sympathetic? ACH. Is everybody okay there? Okay. And this is where we get a lot of confusion because most people will say norepinephrine and epinephrine sympathetic. Is that necessarily the case? No. So all preganglionic neurotransmitters will be what? ACH. 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 All preganglionic neurotransmitters are acetylcholine. No exceptions. Maybe a few, but no exceptions for this class here. All preganglionic neurotransmitters are acetylcholine. And look, it's even in blue, like a blue light special. All preganglionic neurotransmitters are acetylcholine. It doesn't matter if I'm talking about the parasympathetic or the sympathetic nervous system. Everybody's okay there? All right. What happens post-ganglionic, however? Post-ganglionic is where things get interesting. All right. So let's talk about post-ganglionic parasympathetic. There are how many major types of receptors? Post-ganglionic parasympathetic receptors. How many are there? 1, 2, 3, 4. How many people think 1? How many people think 2? How many people don't know? Okay. Hey, you got honesty. There are actually 2 broad receptors. Okay. So there's something called a nicotinic receptor, and there's something called a muscarinic. A muscarinic receptor. Okay? And what neurotransmitter do you suppose exists in the synapse there? Somebody said it. Speak up.
In the what?
ACH.
Right here, at this receptor site, what neurotransmitter am I dealing with? Postganglionic.
In the parasympathetic.
Parasympathetic, postganglionic. Somebody said it. I just want a couple more people to say it if you know it. Sorry. ACH, acetylcholine. Absolutely. So, parasympathetic, acetylcholine before the ganglia, acetylcholine after the ganglia. Would you guys agree? Anytime I have a receptor, I have what? I have a synapse, right? So, nicotinic receptor sites, muscarinic receptor sites, synapse, acetylcholine. So, the somatic nervous system's easy. It's acetylcholine all day long. Parasympathetic nervous system's really easy. It's acetylcholine and acetylcholine. So, both preganglionic and postganglionic. Okay, so let's talk about what happens when acetylcholine acts on a nicotinic receptor. What am I generally going to be acting on here? Nicotinic. Muscles and organs, primarily. Would you guys agree? Muscles and organs? And what are the actions that we're going to run into? Parasympathetic. So what do you suppose? Let's talk about our heart as an organ.
It's going to decrease.
Okay, decrease the rate?
Yeah.
Okay, decreased heart rate. So, if I have a parasympathetic response, acetylcholine, and acetylcholine acts upon a nicotinic receptor, what's going to happen to my heart rate? It's going to decrease. Everybody's okay there? All right. What about the muscle, the smooth muscle, and my airways? What do you guys think there? It's going to not relax, constrict. Yes, I'm going to have bronchoconstriction. So if my parasympathetic nervous system runs away and I have lots of nicotinic receptors being activated, I'm going to have bronchoconstriction or bronchospasm. So are there medications that we can give that act upon, that antagonize acetylcholine in the parasympathetic nervous system? Yes. Medications that block right here. And these medications include things like atropine and Atrovent, which is a nebulized medication we give a whole heck of a lot of. And Atrovent works here by blocking acetylcholine, and that's why we call it a anticholinergic medication. Atropine and Atrovent are anticholinergics. They block acetylcholine here at this receptor site, and they prevent the bronchoconstriction associated with activation here. Are you guys okay there? Everybody's okay? All right.
Mr. Are you calling that postganglionic? That part?
Yeah, this is all postganglionic here. Yeah. So the ganglia is here. Yeah, this is before, and this is after here. Yeah. Everybody's okay there? All right. Where do muscarinic receptors primarily act? Okay, some muscles and glands. Yeah. Primarily what we have to worry about with a muscarinic response will be secretions. And have you ever been to surgery or seen a surgery? And sometimes when patients get lots of secretions, we will give them an anticholinergic agent like atropine, and it'll dry their secretions up. It'll dry them up. Because atropine, again, blocks acetylcholine here at nicotinic and muscarinic receptors. So you guys okay with that? So atropine not only blocks here, but it can block here as well. And so in some cases, and you may run into this in the bronchoscopy. Does anyone know what a bronchoscopy is? Basically a big scope that goes into your lungs, and you can look around in the lungs with that scope. Sometimes you can get a vagal response, which is too much of this here, right? And we can give atropine to block here and get that heart rate to go back up. So that's something that you may run into a little later on in clinicals. So is everybody okay on what happens with a parasympathetic response? What's going to happen to our heart rate? It's going to decrease. What's going to happen within our lungs potentially? Okay, I'm going to have constriction and increased mucus, increased secretions in the lungs. Okay? All right. So let's talk about the sympathetic nervous system. Are there different receptors for the sympathetic? Postganglionic. Yes. What are they? What are they? They're the alpha, right? And alpha kind of looks like a little fish, like that. It's Greek. Alpha and beta. Okay. Are there different subtypes of alpha? Yes. Or I only care about one type here in this class, and that is alpha 1. Do I have different subtypes of beta receptors? How many? We actually have more than 2, but there are only 2 that I care about here. There are beta 1 and beta 2. Are you guys okay there? Beta 1, beta 2. Okay. What is the primary neurotransmitter at these sites? norepinephrine. So norepi, norepi, norepi. Okay, let's test. I want to test you guys real quick to see how you're thinking. Preganglionic. Preganglionic, what is the sympathetic neurotransmitter? The CH, acetylcholine. Postganglionic, what is the sympathetic neurotransmitter? Norepinephrine. All right. Preganglionic, what is a parasympathetic? Postganglionic, what is a parasympathetic? Somatic, what is the neurotransmitter? ACH. All right, you guys got it. You guys have got this. Excellent. All right. Now, are there different effects that occur at each of these receptor sites? Yes. If I have activation of an alpha-1 receptor, what will happen? Do you guys remember from anatomy and physiology? What will happen? Vasoconstriction. My blood vessels are going to constrict. Is that a good thing necessarily? Yes and no. If my blood pressure is low, can that be a good thing? Yeah, I can squeeze those vessels down and increase the blood pressure. If I have hypertension and my blood pressure is really elevated, is that a good thing? No. Okay. But the primary action at an alpha-1 receptor is vasoconstriction. Everybody's okay there? All right. So, let's talk about beta-1 and beta-2 receptors. And let's I'll inject a little saying that will help make this a little easier. How many hearts do I have, generally? One heart. Would you guys agree? How many lungs do I generally have? 2 lungs. So, beta-1, I have 1 heart. Beta-2, I have 2 lungs. So where do you think most of my beta-1 effects are going to be? The heart. There you go, the heart. All right, good, good. And what kinds of effects are we going to have at the heart? What's going to happen to my rate? Okay, if it decreased here, it's going to increase here. What is going to happen to the contractility? How hard it beats? It's going to beat harder. Yeah, it's going to be harder. I'm going to have increased contractility. Okay? What about automaticity? What does automaticity mean? Automaticity of the heart. That's basically how the pacemakers are functioning. And the pacemaker, of course, is generally going to be the SA node, and it's automatic. And so I'm going to have increased automaticity. That means the pacemaker is going to be firing faster automatically. What will that cause? Heart rate increase. Increased automaticity, increased contractility, increased rate. And then there's something called the speed of conduction. How quickly impulses go through the heart. That increases as well. Okay. So that helps me run away from that bear or that cougar or whatever is chasing me, and probably I won't be able to outrun it and I'll die, but we'll give it the old college try nonetheless. All right, so let's talk about beta-2 in the lungs, finally, because this is where we want to be. Right? What happens if a beta-2 receptor is activated in the lungs? I have bronchodilation. I have bronchodilation. And that's kind of one of the key points to this whole pharmacology class, right, is bronchodilation, because we're going to want to do a whole lot of that, and you guys are going to do a whole lot of that next semester, giving bronchodilators. So if I give a bronchodilator, where do you suppose it's going to work? In the lungs on what receptors? Beta-2. Absolutely. Absolutely. And that's why this nervous system stuff is so important. Okay, let's go ahead and just run down it real quick to make sure we're okay on the nervous system. Sympathetic nervous system. Preganglionic neurotransmitter is what? ACH, acetylcholine. What helps break acetylcholine down? ACHE, or acetylcholinesterase. Okay, postganglionic, what is a neurotransmitter? Norepinephrine. Is epinephrine as well? Yes, I can run into epinephrine, yeah, because it's there, but primarily it's norepinephrine. If I give somebody epinephrine, will I have the exact same effects as norepinephrine? Pretty much. Yeah, pretty much, yeah. Again, because they're both what? Norepinephrine and epinephrine are both considered catecholamines. Okay? All right. So, if I have activation of alpha-1 receptor, what's going to happen? Vasoconstriction. And what will that do to my blood pressure? It's going to increase my blood pressure. Okay? If I have activation of a beta-1 receptor, what is that going to do? Increase my heart rate, increase the contractility, automaticity, and the rate of conduction. Excellent, excellent. If I have a beta-2 receptor being activated, what will happen? Bronchodilation. Everybody's okay there? Okay. It is 9 o'clock. You guys want to take a 10-minute break? Yes, let's take a 10-minute break, and we will pick it back.